Good evening, the respected chairpersons, faculty members, and my dear colleagues. I am Darshan, a second year MBBS student from Madras Medical College. Here, going to present a case titled "An Unfolding Neonatal Mystery Moving Beyond Common Diagnosis." So, moving on to the next. This was a late preterm male neonate born at 35 weeks, 5 days of gestation, with a birth weight of 1,660 grams, making him a low birth weight infant. He was born to a 27-year-old female G2P2L2 mother. The antenatal period was uneventful. However, the anomaly scan performed the 23rd week showed a mild cystana magna, echogenic bowel, and left congenital talipes equinovarus. At 35 weeks, the mother developed severe oligohydramnios, for which an emergency lower segment cesarean was done. The baby had a normal perinatal transition after birth. So let's move on to the next slide. During the early neonatal course, the baby developed mild respiratory distress with a Silverman-Anderson score of 1 out of 10, which was managed with a non-invasive respiratory support. Cardiovascular examination revealed no murmur, and the abdomen was soft without organomegaly. The baby also presented hypoglycemia, initially controlled with a glucose infusion rate of 6 milligram per kilogram per minute, and a baseline investigation showed hemoglobin of 14 grams per deciliter, total leukocyte count of 7,200 per microliter, and absolute neutrophilic count were also known, but thrombocytopenia with a platelet count of 80,000 per microliter. In view of respiratory distress, hypoglycemia, and thrombocytopenia, neonatal sepsis was considered as the initial working diagnosis. Next slide. The turning point in this case occurred when the baby was noted to have a wider anterior fontanelle and a macrocephaly on clinical examination. These findings were not explained by sepsis or isolated insulinemia, and raised suspicion of an underlying intracranial or genetic pathology was suspected. As a result, we have ordered an neuroimaging, which is in the next slide. Next slide. Neuroimaging with CT brain revealed extensive intracranial hemorrhage with tonsillar herniation. There was effacement of left lateral ventricle, third ventricle, and fourth ventricle due to mass effect, along with a significant midline shift. These findings indicated a large intracranial bleeding causing raised intracranial pressure and brainstem compression, constituting a neurosurgical emergency. In view of persistent thrombocytopenia associated with extensive intracranial hemorrhage, we consider several differential diagnoses. Yes, sir. The differential diagnosis have been listed down here. It is alloimmune thrombocytopenia, and then sepsis with disseminated intravascular coagulation, congenital infections, and immune-mediated thrombocytopenia. Next slide. As the neonate had a severe thrombocytopenia with suspicion of neonatal alloimmune thrombocytopenia, the treatment was initiated with IV immunoglobulin, random donor platelet transfusion, and corticosteroid to rapidly increase the platelet count and reduce immune-mediated platelet destruction. Although the ideal diagnostic workup of non-immune neonatal autoimmune thrombocytopenia workup was not done due to some logistic constraints. As neuroimaging showed intracranial hemorrhage, a neurosurgical opinion was also obtained. Since there were no indications for surgical intervention, the baby was managed conservatively with close neurological monitoring. Because the baby had features suggestive of neonatal sepsis, sepsis screening and blood culture were also sent. The CRP was elevated, supporting an inflammatory or an infectious process. And then empirical first-line antibiotics were started awaiting for culture results. Coagulation profile also showed an prolonged PT and INR indicating coagulopathy. In view of bleeding risk, particularly in the setting of thrombocytopenia and intracranial hemorrhage, fresh frozen plasmas were transfused to replay deficient clotting factors and to correct that particular coagulopathy. Torch panel was performed and the result was cytomegalovirus IgG positive. However, cytomegalovirus IgG positive alone does not confirm congenital infections like CM infections. Considering the neonatal thrombocytopenia, maternal causes were also evaluated. The mother had no history of thrombocytopenia, and screening for autoimmune disorder, including antinuclear antibodies, was negative. Hence, maternal immune thrombocytopenia and autoimmune mediated neonatal thrombocytopenia were also ruled out. Next slide. Between days 3 and 10 of life, the neonate developed several red flags. Like there was refractory hypoglycemia requiring a glucose infusion rate of up to 14 milligram per kilogram per minute, suggestive of persistent hyperinsulinism. This was supported by inappropriately elevated serum insulin level of 12.33 microinternational units per ml during hypoglycemia. The baby also had persistent thrombocytopenia with anemia, that is bicytopenia. In addition, the infant also developed recurrent apnea requiring mechanical ventilation, indicating severe systemic illness and intensive care management. Next slide. Between the day 10 to 20, the baby also showed progressive multisystem involvement. There was progressive abdominal distension, hepatosplenomegaly, development of neonatal cholestasis, worsening of cytopenias, deranged LFTs, and then elevated inflammatory markers, and serum ferritin was also elevated. These findings strongly suggested some hyperinflammatory syndrome associated clinical findings. Next slide. As the baby's condition progressively worsened, on looking after this, baby's condition progressively worsened, severe neonatal sepsis remained a possibility. However, the persistent cytopenias and then hepatosplenomegaly and hyperferritinemia were not adequately explained by sepsis alone. Hence, congenital cytomegalovirus infections was considered because the TORCH panel was positive for cytomegalovirus IgG positivity, although isolated IgG positive represents maternal antibody could have been transferred transplacentally, reaching the fetal circulation, leading to thrombocytopenia, means leading to CMV IgG positive. However, the combination of progressive hepatosplenomegaly, cytopenias, liver dysfunction, and markedly elevated ferritin strongly favored some hyperinflammatory syndrome. Next slide. By days 20 to 23, the baby entered the terminal phase of illness with persistent fever, progressive hepatosplenomegaly, and bicytopenias, and there was marked hyperferritinemia, hypertriglyceridemia with a triglyceride level of 320 milligram per deciliter, and hyperfibrinogenemia with a fibrinogen level of 0.95 grams per deciliter, which strongly suggested lymphohistiocytosis based on the HLH 2004 diagnostic criteria, which I have added in the next slide. Next slide. Now, the diagnosis of this HLH can be established either by identifying a pathological genetic mutation in the child, or by fulfilling at least 5 out of the 8 HLH 2004 diagnostic criteria. Our patient fulfilled 6 of these criteria, making HLH a most likely diagnosis even before genetic confirmation. And then, in order to further strengthen the diagnosis, I've also added the genetic result. Excuse me. Which has been added in the next slide. Next slide. To confirm this diagnosis, a whole genome sequencing was also performed. It identified 2 heterozygous variants in the UNC13T gene, one in exon 25 and the another in exon 31. The presence of 2 different variants in the same gene suggests compound heterozygosity, confirming familial hemophagocytic lymphohistiocytosis type 3, which is an autosomal recessive disorder. Now, based on this clinical presentation, laboratory findings, fulfillment of HLH diagnostic criteria, and whole genome exome sequencing, demonstrating compound heterozygous variant in UNC 13D gene, the final diagnosis was made as familial hemophagocytic lymphocytosis. Just going to add on next slide. This is the diagnosis, and let's move on to the next slide. Now, let's just have a broad, wider, and means narrow, just a superficial view about what is HLH. HLH is a potentially fatal disease characterized by dysregulated immune response. In this, response towards an antigen. As a result, there will be uncontrolled activation of immune cells and life-threatening cytokines. HLH is of two types: primary or secondary. Primary has familial inheritance, and secondary has autoimmune infection or malignancy. Incidence of neonatal HLH is 1 is to 50,000 or 1 is to 15 lakh. Mode of inheritance is autosomal recessive or compound heterozygous. Next slide. Etiology of primary HLH. There are totally 5 types. The etiology of type 1 remains unclear. Type 2 is due to mutation in PRF1. Type 3 is the one which is present in our case, which is UNC13D. And type 4 is STX11. And type 5 is STXBP2. Next slide. The clinical features usually develop in the months of 2 to 6 months, but in our case, it is an atypical presentation with fever, hepatosplenomegaly, and thrombocytopenia, which will be present consistently and throughout the clinical course. And then there may be jaundice, CNS involvement showing seizure, raised intracranial tension, tone abnormalities, cranial nerve palsy, ataxia, encephalopathy, or spinal fluid pleocytosis. Cutaneous manifestations are erythroderma, generalized purpura, morbilliform eruptions. Non-immune hydrops include fetal hydrops, non-immune hydrops, fetal distress, and intrauterine. Now moving on to the management. The management is based on HLH 2004 protocol, in which we will be giving the patient dexamethasone, etoposide, and cyclosporine. But the definitive management for this condition is allogeneic hematopoietic stem cell transplantation. Supportive management include cotrimoxazole and IVIG once every 4 weeks. Refractory HLH has no standard definition. One et al. Defined it as failure to achieve at least a partial response 2 weeks following a standard therapy. That is, even after the therapy, the patient is not able to show any improvement or is in the same condition. This is what refractory HLH means. Next slide. In case of refractory HLH, we go for anakinra, which is a interleukin-1 receptor antagonist, and then anti-thymocyte globulin, alimtuzumab, liposomal doxorubicin, etoposide, and methylprednisolone, ruxolitinib, and then imapalanum. Next slide. The prognosis of this familial hemophagocytic lymphohistiocytosis is poor if we leave it untreated because of progressive hyperinflammation and multi-organ failure, which is the consequence of this particular disease. The only curative treatment for this disease is the hematopoietic stem cell transplantation with appropriate treatment and success rate of 64%, 64% up to 3 years. However, without definitive treatment, long-term survival remains poor, and median survival range is around 2 months. Next slide. Now, let me tell why this case matters. In the conclusion, let's move on to the next slide. In the conclusion, familial hemophagocytic lymphohistiocytosis is a rare but life-threatening hyperinflammatory disease in neonates. Early diagnosis is challenging because its presentation often mimics neonatal sepsis. However, prompt recognition and early initiation of HLH HLH-specific therapy are crucial as delayed significantly worsens the prognosis. In many persons, thrombocytopenia is one of the earliest manifestations and should raise suspicion, particularly when associated with persistent fever, hepatosplenomegaly, and then hyperferritinemia or unexplained neurological involvement. Uh, treatment should be started immediately with just the clinical findings because waiting for a genetic report in case of any remote areas or in low setting hospital can further aggravate the condition. As a result, by just with the clinical findings, we should immediately start the treatment. And finally, the diagnosis of this pathological variant in a program demands genetic testing so that we could counsel the patient, counsel the parents, thereby uh, preventing further transfer of this particular disease. And next slide. And with this, I would like to conclude my presentation, and I would also like to thank Dr. Rinsky Abdul Kalam, who is a DM resident in Department of Hematology, who helped me finding this case. And I would also like to thank the panel of judges and the association, Praveen sir and Akshaya ma'am for giving me this wonderful opportunity. And thank you.
Thank you, Darshan, for your presentation. I think we had a similar case a few months ago presenting in our forum, and that was an adult patient, I remember, a male adult. I think Akshaya may remember. Anyway, thank you, Darshan. Your presentation was good. Over to the panels and over to the other senior members for their comments.
That was a very good presentation. Another good learning experience.
Thank you, sir.
I've never seen a case like that. Thank you.
Very well presented. Darshan, the thing is that I'm an obstetrician as well, but I haven't come across this case in any of the neonatals that I've seen. So it was really interesting and it was very good to learn about it. But just let me get this right. Again, did you say that this genetic thing has got something to do with consanguinity?
Ma'am, actually, yeah, ma'am. If there is a genetic transmission in a particular family, and if there is any closer relative marriage or consanguinity, there is increased chance of transmission of this particular disease because it is autosomal recessive disorder.
Yeah.
And suppose if two carriers marry, and there is high risk of transmission of this particular disease.
Okay, so when we do this genetic testing, are we getting back to these people to say that this is what that can happen so that they can be careful for future generations? Is this something that is fed back to the whole family? Because, for example, if you have the BRCA gene and you have got breast cancer here, it's not just the patient who screen the patient's mother, sisters, daughters. You know, we look to see whether they are genetic carriers. So is there any thing like that being done there?
Actually, in this particular setting, doing a genetic test is relatively expensive. More than expensive, it is time consuming, ma'am. Actually, we won't be doing this particular testing to everyone. Only if there is high suspicion, we will be ordering it. Routinely, we won't be doing this.
Thank you.
Badri Raj here. Just a very few comments. Once again, a very complicated case that I have never seen before. And the only comment I want to make is about the CT scan showing a massive intracranial hemorrhage soon after birth. And I agree with the neurosurgeon's decision not to drain it or operate on it. It was a very extensive hemorrhage. And the hemorrhage pattern, as soon as I saw it, I knew that this must be due to some kind of coagulopathy, because that's not the type of hemorrhage that you see in prematurity. It was a massive hemorrhage and surely related to the underlying thrombocytopenia. So I think I would agree with the decision not to operate on that, as the incidence of recurrence of such hemorrhages would be extremely high. Otherwise, a good presentation, but unfortunately, I am unable to make any comment about the disease itself. And once again, I read about it last night, knowing that I'm one of the panelists this morning, but I know nothing about this, but I did learn a lot. A good presentation. Thank you.
Thank you, sir.
I would like to add a point here, Madam Pramila ma'am.
Yes.
You were asking about whether the parents are being counseled or whether they are being informed about the results of the genetic testing.
Mhm.
Ma'am, this is in Institute of Child Health. We have a genetics department.
Mhm.
And it is through the genetics department that this kind of genetic testing is done for deserving cases. It's not possible to do a screening type of testing here. So deserving cases like this, of course, they are tested there, and definitely the family is included. So in this case, the family must have been informed about the consequences or the future prospects for them.
Yeah.
I'm sure.
During pregnancy, fetal, the fetal medicine scans are done, isn't it? They hadn't picked up any of this hemorrhage or anything. So all this happened after birth, you think, or was it there even just before birth when the membranes ruptured?
Ma'am, initially, yeah, ma'am. During preterm, there was no significant finding from. Only thing was there was a structural deformity in the leg, and then dilation of cisterna magna, which indicates some brain malformation and all those things. But after after the birth, the disease has started to progress.
Okay.
Initially with the respiratory distress, and then with hypoglycemia and then thrombocytopenia and all that.
Yeah, I'm so glad she had an elective cesarean and not a forceps delivery or something. Then you'd have blamed us obstetricians for putting the forceps on the head and creating this hemorrhage. So an elective cesarean was a very clever decision to do at that stage.
Any comments, Dr. Kanasamy, who is also on the panel?
Well, as you said, that is one of the very rare cases. So, only thing is, parent counseling is, I think, once you know the diagnosis, it is necessary so that the future children may not have this problem. So, I think genetic counseling of the parents is certainly necessary once the diagnosis is made. That's about the only comment that I have on this patient. And as you said, it's another rarer cases which I have not heard. Only Google helps me to know a little bit about this disease.
Yes, sir. I think they would have been counseled, or probably they are in the counseling sessions, attending sessions, maybe.
Okay, that would be nice. Yeah.
Good. Okay, thank you very much for all the students who have come here. I hope they have learned something from the presentation of these two unusual cases. And as I mentioned before, please come forward and present any case, even if it is a simple case. Please come forward to do that. It's all about learning how to present cases, how to discuss, how to answer questions thrown at you by the examiner. So all this would help you with your presentation. Thank you.
Sir, I think shall we formally wind up the session, sir?
Yeah. If there is no one else has any questions, yes,
questions,
please.
yeah. If no one else is having any suggestions or questions, I think I take this opportunity to thank first our panelists for their excellent inputs, especially Dr. Pramila has given us a lot of inputs, and of course, Dr. Raj Murali, sir, you even though you said you were not having much to say, but still you did say about the CT scan picture. And all of them are well taken and very valuable inputs for all of us, including the students as well. And also must thank Dr. Varadarajan for his inputs as well. He has left earlier because he has some of the work he had mentioned in a message. So I thank the students for taking the initiative to come over and present. Congratulations to Adityan and to Darshan. And
Thank you, ma'am.
thank you, sir. I wish to thank the foundation for giving this opportunity for the students. And I must thank Badrinath sir for giving me this opportunity to moderate, or rather, what to say, to oversee this session. Uh, Thank you. Thanks all the students who have joined today. I think there were good numbers today.